and wish you very much a good afternoon or good morning, depending on where you are. As Executive Director at Resilience First, it's my pleasure to welcome you all to this webinar organised by Resilience First. Resilience First's mission is to help build resilience across business communities, whether those communities be defined by geography or special interest. Please do visit our website, resiliencefirst.co.uk, to see the many projects and events we organise in an effort to help understanding and application of resilience. We've recently formed a strategic partnership with the Resilient Shift organisation, so both our reach and output have expanded for the greater good. The title of our webinar today is Zoonosis, Avoiding the Next Pandemic. And while we continue to battle the current pandemic, we should be alert to and prepared for the next one, which will come down the road at some point, hopefully not soon. It's important not to just to identify the lessons, but also to apply them so we are better prepared next time. Adapting to disruption is an essential part of being resilient. Now, around 3/4 of new human diseases originate in animals. Jumping the species barrier to humans has been a long and rather sorry tale. As climate change reduces natural habitats, the proximity of wild animals to humans will only grow, and hence species transfer will become more likely. And in the recent past, the world has experienced acronyms like SARS and MERS, H1N1, Ebola, and now COVID-19, to name but a few of the viruses that have afflicted us. Then there are the many bacteria that have caused us harm, coupled with their increasing resistance to modern antibiotics. And the human death toll and suffering continues, sadly, to mount. It is therefore reassuring to hear that the G7 meeting at the weekend before last announced a new research centre in the UK, which will try to prevent or at least warn of zoonotic diseases. But it's rather ironic that the centre at Pirbright was the focus of an accidental release of the foot and mouth virus in 2007. Hence, while we explore the origins of COVID-19, and that's up for dispute, we should also be alert to some unintended consequences of scientific research. To learn more about this fascinating topic and the issues of surveillance, inequalities and behaviours, we're privileged to have with us today an expert in the field and leader in antimicrobial research through the Trinity Challenge. Welcome to Dame Sally Davies, former medical officer for England and now Master of Trinity College, Cambridge. To chair the proceedings and to introduce our keynote speaker today, I'm delighted also to welcome Sir Andrews. Sir has a place on the advisory board of Resilience First and is also vice chair of the National Preparedness Commission, which I'm pleased to say is supporting our webinar today. Sir will offer some opening remarks by way of scene setting and will then lead a discussion with Dame Sally before inviting you, the audience, to pose your questions to the speaker. Now, please do use the usual hand symbol to raise a question, but I do ask if you would kindly mute your microphone throughout the main session to minimise background noise. The chat facility is also open to you to use if you would appreciate, but we would appreciate it if you could keep your comments brief and to the point so that the chair can keep an eye on those and draw on the outputs. Lastly, I should add that the proceedings are being recorded and we will share a written summary and the slides Dame Sally uses in the presentation in the next few days. So with that, I will pass across to Sir Ian. Sir Ian, the virtual floor is yours. Thank you.
Robert, thank you, and good afternoon, everyone. I should perhaps begin by explaining why I think I've been asked to chair this afternoon's conversation. For 5 years between 2013 and 2018, I was a non-executive director of NHS Digital. That said, I am no more than averagely competent when it comes to IT, although my children might dispute that. And my only experience of healthcare is as a patient. But I've long been convinced that when things go wrong in any organization, whether in the public, the private, or the third sector, it can invariably be traced back to a failure of governance in one form or another, which means being clear about who is responsible, to whom, and for what. I first met Dame Sally when she was the Chief Medical Officer for England of the Department of Health, as it then was, and the Senior Medical Advisor to the UK government. Today, she would be as instantly recognisable as is her successor, Professor Chris Whitty, although health is, of course, a devolved function, and there are 4 separate national health services in the UK. Prior to that, she had a track record of innovation and leadership in healthcare, which included pioneering the establishment of the National Institute for Health Research, which transformed the approach of the NHS to clinical research and prompted the collaboration between academia and the health service, which has been so central to our response to the coronavirus pandemic over the last 18 months. Excuse me. She's also perhaps best known now for her efforts to raise awareness of the potentially existential threat from what is known as anti-microbial resistance, for which she's been the UK government's special envoy since 2019. Alongside human health crises, AMR has been identified as a Tier 1 security risk in the National Risk Register since 2015. And an independent review the following year warned that if no action was taken, it could account for 10 million deaths globally by 2050. You may also be surprised to know, with all the attention currently being given to the pandemic, that alongside numerous biosecurity strategies, we are actually midway through a second 5-year national action plan against a 20-year vision to tackle AMR. In her annual report as Chief Medical Officer in 2018, Sally set out the case for what has become known as population health management. And that argued that we might have lost sight of the fact that what really matters is keeping people healthy, so that we avoid having to treat them after they become ill. An aging and growing population living longer with more complex medical conditions poses a huge challenge to global health systems and economies, even without the additional pressure of a pandemic. The case for transforming the way we think of the NHS as a genuine national health service, rather than as what is in effect a national illness service, is overwhelming and well made in her book, Whose Health Is It Anyway?, which was published earlier this year and which I commend to anyone who cares about the future well-being and prosperity of our society. With that wealth of experience behind her, we are indeed very fortunate that she's been able to carve out time to be with us today to speak about zoonosis and how to avoid the next pandemic. For those of us who may not be instantly familiar with it, zoonosis is defined as a disease which can be transmitted to humans from animals, and that accounts for as many as 2/3 of human infections. Dame Sally, you're very welcome, and the virtual floor is yours.
Thank you, Surrey, and thank you, Robert and Bina. If you could put the first slide up, we will go through a short set of slides to kind of set a conversation. You've already heard about the fact that about 2/3 of infectious diseases in humans anyway are caused by pathogens shared with wild or domestic animals. And zoonotic disease organisms include those that are both endemic in human populations, that means they're there most of the time, things like malaria would be one example, or enzootic in animal populations with frequent cross-species transmissions. So this is a big disease burden, causing 1 million cases of illness in people and millions of deaths every year. So if you look at the next slide, I've borrowed pictures from a number of people to try and make the case to explain it. This is for viruses, and clearly many viruses have natural hosts where the host animal is not ill with it. And bats are important. And I remember going to a dinner 6 or 7 years ago in Hong Kong with someone post-SARS who specialized in viruses in bats. And he was very excited over dinner. He'd come across 21 new viruses in the species of bat he looked at that we didn't know about. So there are plenty. They then often get into other animals where the animals may have moderate to severe symptoms, and because we live closely with those animals, often because they're part of our food chain or pets or transport or something, then it is easier for them to move across and jump into humans. So if you think about where we are with COVID, we know it came from a bat. Did it go through another animal en route to humans? We don't know. There's a debate. Frankly, at this point, it doesn't really matter. We know about flu, and the two on the left, H5N1 and H7N9, are different types of flu. They are present in birds a lot of the time, but they can move to other birds. What we really worry about is that a nasty bird flu, which may not make them ill, hops into a human when they've got an ordinary flu, and then that they recombine because the bird flu normally doesn't transmit human to human, but that recombination allows it to jump human to human. We've had some other SARS viruses. COVID is a SARS virus, the original one, but also MERS, Middle Eastern Respiratory Virus, which seems to come from the camels and is very common, as you gather there, and there have been deaths. So that's about how they're normal in some animals, where they just live there, how they then jump into other animals that are closer to us and move forward. If you look at the next slide, please, Bina, what you can see is a list of some of the known. And I've put in red the kind of common ones, or the ones we hear a lot about. I'll come back to some of these, but I think it's quite humbling when we look at how many of these we know and we worry about and we're used to treating, though some of them, I have to say, fish tank granuloma was new to me as I started looking up the list. So we're all learning all the time. What I did want to show you was the next slide, which comes out of a relatively old paper, but along the bottom they've got flu. Of course, it doesn't have West African Ebola, which killed about 14,000 people, or at the right end, nor does it have COVID, and we know that at least 5 million have died, and it's probably higher. But what it shows you is why we have always, until now, prepared for flu. That flu is frequent as pandemics, jumping from other animals. The 9/10 flu outbreak was called swine flu. It jumped from swine, probably in Mexico, and that causes most of the deaths. We're still not at the level that at the far left, the Spanish flu in 1918 was, and I think it's also worth pointing out to you that the biggest death rate was not in the first and second waves. The very big death rate was in the third wave, but they didn't have vaccines, so that should protect us. Meanwhile, if you look at that, there's a tipped over bottle in 1977 of Russian flu. That was a flu, we believe, that escaped from a laboratory. So we do have to think about laboratories. But look at the deaths from the other ones. They're big, but not massively significant. So what we actually need is to be able to see where the risks are, watch for spillover, and get rid of it as soon as there is spillover, so it doesn't grow into an outbreak that can become a pandemic. So you hear me talk about spillover, then an outbreak, then a pandemic. So if you look at the next slide, all I've done in this one is lay out what has changed and why zoonoses are on the rise. And I think Robert put it very well, you know, as the population rises, people encroach more and more on the habitats of these animals. I mean, the bats, there are people in Indonesia that collect bat droppings for a purpose. You know, so there is interaction. But if I go back to the West African Ebola in 2013-14, the case 0 was a 6-year-old boy who was playing outside his village in a hollowed out dead tree where bats lived and there were bat droppings. And that's what set it off. Climate change is clearly having an impact. And of course, pandemics are helped by travel. You can map, and people have done it. It's 1918 Spanish flu, shouldn't have been called Spanish, it didn't start there. They just reported it better and earlier than others. But you can map it moving with boats and things. And now, of course, with globalization and air travel, it travels much more easily. And pandemics are a higher risk. Again, a reason for funding the insurance to make sure we can tamp it down very quickly. The next slide tries to show you the issues of spillover likelihood. And if you look at the left-hand one, it's about rabies. And there is a big reservoir in rabies. It's in bats and rodents, as well as four-legged friends, including wolves and foxes and dogs. But it's quite difficult to get it into humans. But once it's in humans, it has a massive impact. If you look at the right, Ebola virus, there's probably less of it around. And again, if it escapes into humans, it has a massive impact. Whereas the one to the left of that, Toxoplasma, that once it gets, there's a lot of it around, it's often in cats, but if people get it, they're usually not very sick. The Escherichia coli, bang in the middle that this shows you some feeling for, is the one which, if kids don't wash their hands and they're unlucky in petting farms, they pick up and then they can get kidney failure. So you can see that E. coli, which is in our guts, everyone has E. coli in their guts, get the wrong sort from an animal and it can have a big impact. If you look at the next slide, what it shows is two kind of graphs. Look at the top one, and you see there that where the red is, it's the human transmission and amplification, the big outbreak leading to an epidemic or a pandemic. A pandemic just means it's in more than 2 continents and a number of countries. And that occurs when the pathogens from the animals in the wild, as I've been showing you, moves into livestock, and then you get an outbreak. So what you're getting here is the undulations in cream of coming and going or rising and falling of the pathogen levels in the wild, spilling over into the green peak, which is the livestock outbreak where it's amplified, and then it can go to people. So what do we need to do? Go to the lower one. If we detect it early in the wildlife, we can control it. If we detect it early in our domesticated animals, we can control it so that, and if we pick it up early and respond rapidly in the humans, we can control it. So that's what that slide shows you if you like to see it visually. In the next slide, what I've written is, what do we do? Well, you need good infection prevention control and animal husbandry. Interestingly, we call infection prevention and control in humans, IPC. In animals, if it's in the food chain, they talk about biosecurity. But it is essentially about keeping things clean. So you've got to reduce the risk. That means you need water and sanitation and hygiene, wash. It's very difficult if you're in a poor country and you don't have good sanitation, you don't have clean running water, how you manage this for yourself let alone the chickens in your backyard or whatever. So it is very difficult. We can reduce mosquito-driven infections, and malaria is the obvious one, but Zika is actually a pandemic, though it was never called as such, and in Brazil has caused, with infections in pregnant women, microcephaly and dreadful problems. So how do you cope with that? Well, eradicate the mosquitoes. And there's some really interesting efforts and studies going on of introducing a Wolbachia bacteria that stops female mosquitoes having progeny, and that then gets rid of the mosquito population and seems to protect populations. Insect repellents, clothes, etc., and bed nets are all important. What do we also need? Well, we've got to pick up when there's a problem and then treat it effectively. But it'd be even better if we prevent it with vaccinations. So, you know, we are protected in our salmon and trout that are fish farmed in Scotland and Norway, for example, from transmission of infection and the use of antibiotics by the fact that they give each one a vaccine when they're tiny, a mixed vaccine of 3 vaccines. So we can protect them and even their transmission across to us through the food chain, through vaccination. And of course, if animals are ill, we can treat them, we can isolate them until they get better, or we can sacrifice them, whereas I don't think it would go down very well if we tried that with humanity. But if you look in the next slide, what COVID has shown us is that we already had widening inequalities in our population. In men, the gap from 2001 to 2018, the life expectancy so the difference between the least deprived and most deprived in life expectancy extended. It got worse from 9 to 10 years. And in women, you can see it went from 6 to 8 years. So the inequalities are very much there. This is England and Wales data. The next slide shows you something that you've been seeing. We'll have to go on to the next slide. I didn't realize that was animated. Something you've been seeing on the screens in the first wave, but keeps getting lost. Obesity. People with obesity have ongoing inflammation. And we know that people with inflammation, if they catch COVID, do worse. And look at this. Obesity, looking in reception, which is pale blue, as to leaving primary school in dark blue, in all children doubles over primary school, and it's twice as prevalent in the most deprived 10%, which is at the left, as the least deprived at the right. So we have real problems in our communities about how we respond if we capture zoonosis, and the next slide shows you the demonstration of that, which is that COVID hasn't been felt equally. So the most deprived are on the right, and what you see is all deaths in grey, and in COVID they are exacerbated the more deprived you are. And some of that is because of obesity and other chronic illnesses. Some, as you know, is because they're more crowded at home, that they must work, or they're key workers and they're travelling, and also there may be differences in wearing masks and things. So before I finish, I want to highlight 2 other things. The first is in the next slide, that we are in the middle of an acute outbreak, but actually we have a slow pandemic going on, and it's antimicrobial resistance. And some new data that's not yet published shows that every year 1.2 million people around the world are already dying of bugs that infect them that don't respond to the treatments. And so in the top picture, you've got where it's white, we haven't got data, but it gives you a picture of where the resistance is worse and less bad. So please don't get ill in India and over in Asia. Don't get TB in Russia. And if you look at the bottom left, you can see the further south you go in Europe, where actually, and it is related to this, antibiotics and treatments are much easier to buy. You can buy them over the counter. You see more resistance. And then what I've also put on this to show you is a drug resistant index across countries. And I've just shown you, at least I thought I had, yes, I put the arrow a bit high, where we come as the UK. So we have a slow pandemic there. I also wanted to show you in the next slide, because I thought it would interest you and we could talk about it in questions, is something I've been doing over the last year, when I realized that actually data science has moved immeasurably, but public health has not in general adopted it. So, you know, using Excel spreadsheets in Public Health England in COVID, so some of the data was lost, is really sad. So I brought together a coalition of academics from around the world, Hong Kong, Singapore, Brazil, the States, Britain, and places, alongside the private sector, Facebook, Microsoft, Google, Tencent, Legal & General, Aviva, Discovery in South Africa. And between us raised a prize pot and a running pot, and we have been bringing together these great minds to think about data and how best to bring data and analytics to solve the problem of preventing pandemics, responding and recovering better. Some of that's by working across the collaboration, but the big part is that we launched an inaugural challenge inviting innovative solutions. We got 340 amazing ideas from 61 countries around the world. We've got a great judging panel, totally independent from me and colleagues who are running this, and 16 finalists. And on Friday, we will announce who those finalists are, and they are just amazing. They've got modern ways of using data and analytics that extend into low-income countries, and some arise there, that are scalable and are going to be global goods and affordable. So we're really looking to make an impact going forward in this way. So the final slide I wanted to show you was, I just thought you might want to think and talk a bit about what makes for resilience. I'm arguing that we didn't have in this country population resilience because of the obesity and the inequalities, and that then goes through to personal resilience. We didn't have system resilience in general. We had a super health system. I gave my working life to it, but actually we had fewer doctors, nurses, ITU beds than most of our OECD comparator countries. So however wonderful the people and the kit can be, the people are, the kit can be, there wasn't enough of it. We didn't have that resilience. We all know the story about social care and local authority and how it's knocked travel and our economy. I think in this country, we've done pretty well on the knowledge systems, the research, the science, and I feel quite proud of that, particularly because I conceived and set up the National Institute for Health Research, NIHR, and that is the engine delivering all the clinical trials that are giving us answers like steroids save 30% of severely affected people with COVID's lives and things. We did have some planning, but it was for flu, not this. We didn't have enough stockpiling, and I've talked a bit about data. The big issue as well was behavioural science and behaviour, which takes you back into trust. And one of the reasons I set up the Trinity Challenge the way I did was because a lot of the data we need is not in the public sector, it's not in the health sector, it's not in government, it's about behaviours, it's movement, it's attitudes, Facebook picked that up, it's about expenditure. The behavioural data is in the private sector, and by bringing them into our challenge, we made it available through the challenge process from those private sector partners working with academia to do work there. So we need more behavioural science, but for a good pandemic system, you've got to have access to that data, the right time for the right person. I think the other things are clearly things you'll know about. I did think it was just worth mentioning a couple of risks. You'll think of others. Weaponizing and bioterrorism is clearly obvious. But xenotransplantation, transplanting from other animals into humans, whether it's a liver or it's something else, many other animals that we could transplant from have either embedded viruses in their genome or may have chronic viruses in them that we know about or we don't know about. By xenotransplantation, by taking organs from them to save human lives, we might save that life, but there is a risk that we would then be introducing new infections into humanity. So I just thought you'd like to think about that just a little bit, as well as another area of zoonoses that has ethical as well as health consequences, and why we debate these issues. So I'll stop there, Ian, and happy to answer questions. Thank you, Bina, for the slides.
Well, Sally, thank you very much. What a fantastic tour de raison, and a vast quantity of information you put across there. Maybe could I just take you on the antimicrobial resistance, which, as I said, has been a tier 1 security risk of the UK since 2015. This is something which certainly pre-COVID was a huge preoccupation of the global healthcare community. And I wonder if there's a risk that the focus on coronavirus will mean that the pharmaceutical companies are further sort of disincentivized from investing in developing new antibiotics. And I wonder if you could just, for lay folk like me, just expand on how antimicrobial resistance and antibiotic resistance are the same but subtly different.
Right, thank you. And this is my special subject, if ever I were to do Mastermind. So antimicrobials are anti-infectives. They can be treatments against fungi, viruses, bacteria. It's the family name. Antibiotics are the subgroup that work against bacteria. And this is what is exercising people as an emergency at the moment, though we should also be as exercised about fungi as it happens. And of course, we don't have an effective treatment for COVID. There's a new one for flu coming. So they are used interchangeably, but the antibiotic resistance, we're talking about bugs, and there's a real problem now. And that's what the 1.2 million deaths a year across the world relates to, rather than the broader antimicrobial. So what, the risk of this dropping off the agenda, well, it did for the first 6-9 months of COVID, which is a pity because the latest data out on wave 1 in England shows we've grossly overused antibiotics. I don't blame my colleagues. You see someone sick, you want to try anything in the hope it'll work, but actually we've overused them when they wouldn't work and didn't work. And overuse of antibiotics drives resistance. It's survival of the fittest, it's Darwinian biology. But actually, now people are beginning to talk about pandemics. They're recognizing there is a slow pandemic. So with the help of Patrick Vallance, our government chief scientist, I was able to go and talk to the at the G7 to the chief execs of the major pharma companies about the fact that it was time that they worked with us to find a better way of incentivizing the research we need and the development to bring through new antibiotics, because essentially we've got a market failure and the pipeline is empty. And they agreed, and so then we went on to the health ministers and they agreed we had to work on it. Then we went to the finance ministers and they agreed we had to work on it. So I'm feeling hopeful at the moment that I've had some traction through G7 and now I'd better make something of it.
Well done and thank you. You spoke about the importance of planning and preparation, and I mean it's not sort of widely understood that the 2011 pandemic flu response plan envisaged a reasonable worst case of 250 to 300,000 deaths in just 15 weeks. It's more than twice what we've experienced even so far with coronavirus, as well as the NHS being overwhelmed. And I wonder how we ensure that policymakers and politicians remember that abstract numbers translate into real people, and they don't forget what they think they've learned when other more immediate short-term priorities present themselves and attract the sort of populist attention.
So I think that's a really difficult question, and it's in two parts. The first is we model, or the modelers model, reasonable worst case scenario. And it's interesting that in everything that they've modelled, they have overestimated where we ended up dramatically, whether it was a foot and mouth or 10-11 or whatever. So while we need to model for that large number and try and be prepared, it may not be at that level. And we need to be honest that we work to try and prepare for that, but then about what is going on. And I think in 10-11, we were too slow to say, hey, gosh, we're really lucky. This is a mild flu and it's not, and there aren't going to be that many. But then how do we keep this on the agenda? Well, I think we've got to make sure we develop our preparedness going forward so that it's not over-egged now. So some people from my community are calling for all singing, all dancing, surveillance, this, that and the other. It won't work. A, it won't be funded. B, even where it gets funded, after 3 to 5 years, governments will be different and they won't want to continue. We need to have surveillance systems based on data, much as I've been talking about with the Trinity challenge, that actually are always on and are useful for day to day, about strengthening normal public health systems so they work day to day and then they can be amplified and built very quickly when we have an emergency of a pandemic. Because actually, if only we were speedy, we'd just get outbreaks and maybe little epidemics and we'd be able to hit the pandemics. So it is, I think, about not over asking, but being sensible and using digital technologies and genomics now in modern ways. And then remembering that in 5 years' time, there'll be even better ways that will probably be more cheaper and more scalable, and moving it on, not saying we've done it and moved on. But modeling's changed. So for the first 6 to 9 months, the models used in Britain were models based on flu from 2013. Hey, it's about time we use more modern modelling techniques, but the Royal Society's brought other people into this and we do it much better now.
Thanks. The Matt Hancock, the Health and Social Care Secretary, called at last week's NHS Confederation conference for, we need to do things differently, we need to do things better, we need to do things in a change the way we approach these issues, the sort of silver lining, if you like, from coronavirus. And one element of that is, as you touched on, making much more effective use of data. And his remarks were echoed by the chairman of the Confederation and, by the way, a fellow NPC commissioner, Lord Adebowale, as holding the key to healthier, happier and sort of more productive local communities. But this will inevitably mean greater focus on the sort of health inequalities that you described associated with patients' backgrounds, postcodes, jobs, families, lifestyles. And reducing those inequalities, as you brought out very clearly, could become as important as meeting financial waiting time or other performance targets with which public and political attention is apparently preoccupied. And I just wonder how realistic that ambition is, and how likely do you think it is that politicians will take fright when accused of promoting a nanny state or a postcode lottery or the exploitation of data by selling it to private industry? There's some really big contradictions in that, it seems to me.
So there are two areas that you're talking about. The first is data, and can we use data and people's attitudes. I think there's a generation difference here. If you look at the young, they're always sharing data and everything, and I think that a few voices are very strident about not using data. But we need to move away from talking about data as the new oil. It isn't. Data only becomes important when it's aggregated and interrogated. I mean, people not sharing their genomes is fine, but don't think we can diagnose from your genome what you've got. We need to compare it to other genomes in order to really work it out. So people need to understand that it isn't the new oil, and what it is to use it in their interests and the broader interests, which takes you into stopping talking about confidentiality and moving to how do we preserve people's privacy, because that's what we need to do. And that's quite doable in many ways. I'm very impressed by something called Azure in the Microsoft system, where they can assemble massive patient or people data sets and then just drop in a few little statistically irrelevant bits of data, so you can't backtrack and work anyone out, and the end result is good enough statistically. So there are ways of doing that, and our Trinity challenge is picking up on some of that. Handling inequalities is going to be the big challenge, and as you know from my book, I think this is a societal issue, and actually it's something where we have to come together. The NHS can't do it. The NHS has become a national illness service. It needs employers and the whole of society to work together. And I hark back to being a Brummie Cadbury's and what Cadbury's did for their workforce years ago. So did Rowntree's. And actually, it would be much cheaper for companies to invest in the health of their workforce, the workforce families and their local communities, than it would be to suffer another pandemic like this. So we've got to find a way of coming together, and for the politicians to start to think about investing for the longer term, not the electoral cycle, but when you want to invest in health, as opposed to managing ill health, you've got to think of a 10, 20, 30-year cycle, and we really are going to have to do it. Yes, I fear it'll be difficult because of the libertarians, but that's why employers need to understand it's in their interests to help and to insist that the government does things.
That's certainly what you said on data is music to my ears, as you might imagine, as a former non-executive of NHS Digital. What's always struck me is that people seem to be very happy with sharing their most intimate details with beastly private sector corporations, but really object to the idea of sharing it with government or with health services for their own benefit. It's a sort of ultimate contradiction to me. Sort of in the interest of sort of opening up the conversation and not monopolising it, Robert, have you got your hand up?
Yes, thank you very much. Fascinating conversation and presentation, Dame Sally. Thank you. I got the feeling, correct me if I'm wrong, that you were a little bit disparaging about global institutions. I'm thinking of the WHO in terms of their facility to monitor and survey the pandemic opportunities, as I put it that way. And we've had incidents of SARS, we've had incidents now of COVID-19, where countries, for perhaps their own intent purposes, are not happy to share or warn people And if they don't, then the WHO is a bit hamstrung. So do you feel that the idea of having a global institution like the WHO is not the right vehicle for surveillance, and it has to be left to nations, in which case, are they not going to hide what they want?
Well, the WHO is not a delivery organisation. Whenever it tries, it doesn't usually do it terribly well. It was set up to do norms and standards, and it's pretty good at that. When they didn't deliver on malaria, TB and HIV, we set up the Global Fund. When they didn't deliver on vaccines, we set up Gavi, and now we've set up COVAX and the ACT Accelerator. And so they don't do surveillance, they collect data. And I do think we need a proper surveillance network. So the recommendation to the G7 was to set up a kind of surveillance pandemic, what they call radar, but a bit like we do on flu surveillance around the world, that actually labs in every country collate the data and they put it together. And some of them are called WHO reference centres, and they are responsible for collecting it from around the country and neighbouring countries. And then it all gets put together. So we need something like that with much more genotyping, but it will come back to the countries or ODA to fund the surveillance, and we just need to make sure the academics or the public health agency labs are doing the surveillance, and then that it is collected. Then who's going to take the decisions? Well, at the moment it is the WHO, and ideally it would stay with them, but they did delay too long the calling of a pandemic, and everyone worries that this was a political delay rather than anything else.
Thank you.
Brian Collins, you've got your hand up as a former Chief Scientific Advisor. I'm sure you worked alongside Sally in the past.
There were many breakfast meetings that Sally and I met around Sir John's table, and I distinctly remember one where she was going to spend an enormous amount of money on Tamiflu, I think, or not. She may not want to remember that meeting, but I remember it very well. Sally, you talked about the pace of which surveillance systems now need to be put in place in order to react to potential outbreaks and move very quickly. As a person who worked in transport, of course, one of the vectors which we're now seeing the result of is global air transport. And I did a quick look in the last few days just to see how rapidly it has grown in the last 10 years. And it has grown, of course, enormously, and particularly in China, which is interesting enough and as a piece of statistic. Question is, what else is changing so fast that we need to react to that change so quickly that otherwise we will be taken over by a circumstance we don't hear about? I mean, you talked about exchanging data, but it did seem to me in some instances within COVID, the data just apparently, and I'm not inside the tent like you are, didn't get moved as quickly as it should have done in order to get people to make the right decisions in other parts of the world. In other words, the aircraft carried the people in tens of thousands quicker than the information about what they were carrying or potentially carrying was transmitted. And unless we keep ahead of the zoology, the data time constant and the zoology time constant relatively in sync, the zoology will keep on beating us. I just wondered what your reaction was to pace.
Yes, you're right. And it isn't difficult to get data to flow quickly, is it? I mean, it can flow much more quickly than we can on aeroplanes. But it's not just the data must flow, people must look at it and believe it. Yeah. The West or the global North, whatever way you want to call it, had a bit of hubris. We didn't experience SARS. The odd case of Ebola was imported. And actually, we should have watched what was happening in Asia and taken lessons from it, I would argue. So some of it is, you know, our approach. And hey, it's not going to come here, and some is how the data flows. But the other bit we've got to watch, and I mentioned it, but I didn't labour it, was how we are more and more, because of climate change and because of population rises, encroaching on the habitats of animals that transmit these zoonoses. So we know there's a risk of spillover. So what are we doing close to those to try and monitor and then get rid of the problem, tamp it down before it spreads in humans? And I don't regret Tamiflu. I argued in front of the PAC that we needed the insurance, and in fact, Roche have got a new, probably more expensive, but much better drug that you take one tablet, and I think we should now roll over the Tamiflu into the new one.
Excellent. Now, I remember, we could print 2 billion, you can't print 100,000 lives. It was a very straightforward decision as far as I was concerned.
Thanks, Sally. A question in the chat on the behavioural issues. Phil Jones from NBC Universal. Do you think big tech and social media providers and influencers have a role to play in helping to address the behavioural aspects of future resilience and responses?
Absolutely, which is why Facebook, Google, Microsoft and others are very much part of the Trinity challenge. I think they've got to make sure that we're not peddling, having peddled lies and stuff around the place. I think Heidi Larson is working with Hong Kong and Facebook. No, it's with Tencent there, about putting in chatbots that pick up vaccine hesitancy lies and then responds immediately before they've spread. We need Facebook checking things and taking down the vaccine hesitancy that isn't hesitancy but is denial. I understand people being hesitant. Does it work? Is it safe? Ow, will it hurt? That's hesitancy for me. Denial is, I don't need it, it doesn't work, or it's dangerous. So there's a lot of work they can do. And actually, if you look at Facebook's symptom survey, and they do this survey every couple of weeks of millions of people, Johns Hopkins and other universities work with them about what are the questions to ask, and they get the data and analyze it. It's terrifically helpful. So I think they've fallen over backwards to help these big techs, not just me and Trinity Challenge, but broader governments around the place. What I worry about is if governments start to move on, will they move out of this area and not continue? Whereas we need to develop the relationships and the systems and keep them going.
Lord Harris, you've got your hand up. Would you like to come on and ask your question?
Yeah, it follows on. Please see you again, Sally. It follows on from the question from Phil Jones, because a lot of the response that's needed is going to have to relies on public trust. And I accept that Facebook and social media companies, of whom I've been very critical in the past, have actually worked very, very hard to try, and particularly about the COVID virus, to address some of those issues. I think they're struggling on some other aspects of fake news and misinformation, disinformation as well. But do you think, I mean, if you're to tackle the sorts of things you've been talking about, there are big behavioural changes, there are big policy changes that may well be needed around the world. How do you actually get sufficient public trust, given that I think it's been declining during the last 18 months? How do you make sure there's enough public trust and people actually believe when they hear scientists say this is the situation, or this is what we know at this point, that action needs to follow? So how do we be proactive about that?
I thought you were going to ask me about trust in government, and I was going to say perhaps, government could tell the truth and behave in a decent manner and become trustworthy. Because
I take that as a given.
to generate trust, you have to show you are trustworthy. And if you look at the data from, is it YouGov or someone does a survey every year, doctors come out very high on trust, and then scientists a bit below, and politicians, sadly, because so many do care about doing things properly, come out rather low. So I think we've got to take the community with us and talk to them and show them what we're doing and build that trust. I think in general, though not always on vaccines, the public have listened to the NHS and to the doctors and the scientists. I think Tris Whitty's done a great job. So it shows it can be done. It's interesting that some of the biggest naysayers on vaccines turn out to be in the NHS. A nurse has been thrown off the nursing register, and I think we need to be very strict with our own workforce that they understand the science and they get where we are and why. I think it is totally unacceptable for people to put patients at risk of catching COVID or flu from the doctor or the nurse. We should be vaccinated. But it's a long journey building that trust. I think it would have been good, and I've discussed it with a number of people, if we could have had more conversation between, I'll call it government, but the system and the public in a way than we did manage. And the other thing I'd say is, I don't think trust was helped by members of SAGE and other scientists popping up, disagreeing with each other. You need kind of science cabinets where you bring your different views in, you knock them around and you say, this is the best we've got at the moment and we'll stick to that, saying, but we don't know about this, that and the other, rather than someone popping up here, there or everywhere. Most of them have done really well, but there are some. And the scientists need to understand when it's a political decision. To say, don't lock down, the public won't take it, when there's no evidence, is a political judgment. The science judgment is, we have no evidence, it's worked in the East, in Asia, it could work here. This, over to you for a political judgment. So we've got to make sure the judgments are taken in the right place too.
Sally, thank you for that. I'm just got one eye on the time, but Mike Rooney, you've got your hand up. Would you like to come on and ask the question?
It's a pandemic-related question. So, if Dame Sally was still the Chief Medical Officer, would you have done anything different to manage the pandemic?
I'm so glad I dodged the bullet. And I don't know. So not only do I not comment at all on our response, though you've heard me say I admire Whitty and Valence, because it would be unhelpful, particularly sniping from the side, but I know that there's a lot of information and data I don't know. In government, they have access to much more because there are many people collecting it and briefing. I don't have that. There's clearly areas we could have improved, but hey, everyone did their best, and let's learn the lessons and do better another time.
Thanks.
Well, an excellent note perhaps to finish on, Sally. Just on the data thing and trust, it always seems to me that, and I've got my NHS digital hat on here, there's an essential transaction between with the public, that in return for having an outstanding health system free at the point of use according to need, we pay for that by making our data freely available for the common good and to enable future treatments to be developed and better health to be delivered. That seems to me to be an argument which is not being made, but you obviously agree. On which note, Robert, back to you.
Thank you, Cyril. It's been a really good hour, and thank you so much for all of the contributions. So it really leaves me just on behalf of Resilience First and everybody listening to thank both Dame Sally and Cyril for their engagement this afternoon. It really is fascinating, and we appreciate the time that you have. It could be spent elsewhere, but we do really appreciate it with us this afternoon. And also, please do accept Dame Sally's kind invitation to join the Trinity Challenge on Friday. Finally, it just leaves me to say that our next round table webinar will be on the 1st of July, when we'll be launching our guide on operational resilience for non-executive directors. And we look forward to seeing Cyril again at that round table. So with that, thank you, Dame Sally, and thank you everybody for listening. Goodbye and stay safe. Bye-bye.
Thank you.
Thank you very much.